All right. Well, thank you so much, Daniel, for that introduction. And I'm very excited to be part of CPH and collaborate with, many of the faculty on this call and eventually students as well. This year I'm not taking students, but I do hope to do so from CPH relatively soon. And I also have projects that could be interesting for like a 1 year or 2 year type of side project if you find this type of work interesting. And so today I'm going to talk about computational challenges in particular within consumer digital health. I'll note that my research group works on other challenges outside of computation as well. We do a lot of human-centered design. We would like to eventually translate and look at implementation science issues as well. So really, as a research group, we go from ideation all the way to we would like to go to eventually towards translation and everything in between. And computational innovation is part of that. And so that's what the focus of today is going to be on, but it's not everything that we do by any means. So with that, I thought that it would be interesting to just briefly introduce the field of consumer digital health. So as you all probably know, there are a wealth of consumer devices today that record data or that can be repurposed to record data that are highly relevant towards diagnostics and monitoring of health conditions. So think smartwatches, smartphones, or even maybe social media, or consumer health devices like a blood pressure monitor, a continuous glucose monitor, or a ring, maybe kind of in the middle there. And many other devices that can be used in remote settings by patients. And so from a computational standpoint, what we would like to do is to take these data and feed them into machine learning models that can make predictions. So I assume everyone on this call is very familiar with that. And what types of predictions do we make? Well, diagnosis and screening, which is very common in AI for healthcare, as well as probably equally as common in our field, but perhaps not too common in a lot of other subfields of AI for healthcare, is this idea of repeat health monitoring, where we're doing remote patient monitoring or trying to quantify a patient's state to create an adaptive digital therapy. Now, this does occur in other data modalities, but it's perhaps enriched in consumer digital health compared to some other ones. So I'll try to spend about equal time in each of these. And so for today, since this is the computational precision health group, I thought it would be interesting to talk about some, but not all, of the central computational challenges in consumer digital health informatics. And so the three that are kind of centered in my mind right now have to do with the subjective and nuanced nature of the health conditions that we often want to predict in this field. So they often tend to fall in psychiatry, neurology, and the diagnoses of these conditions can be quite nuanced. In some cases, especially in psychiatry, can be somewhat subjective as well. And so that becomes really difficult in terms of the label encoding. And so that's a big challenge if you're trying to be objective when you're working with subjective data. And so the opportunity here is human in the loop AI, where we can have humans and AI models work together, where the AI models can do what they're good at, which is being highly objective in their analysis of the data. And humans, be they clinicians or non-clinician health workers or parents of children who are, the subject of the diagnosis, or whoever it is, educators can work together with an AI model in a synergistic manner. And so that's the first thing I'll talk about. The second, it has to do with not the output of the models, not the label, but rather the input. So the inputs to these remotely collected data are often highly noisy and heterogeneous. Due to, it's collected at home, it's not a controlled clinical setting. And so the opportunity here from a computational perspective is personalized self-supervised learning, which is this idea of, and sometimes computational people get mad at me when I say this, but like a personalized foundation model, where we're essentially doing self-supervised learning on just one person's data, and it's really optimized towards making repeat predictions for that one person. So I'll talk a little bit about that, and this can enable various digital interventions. And then finally, the third challenge I want to talk about has to do with different data qualities across devices. So for example, Macs versus Windows can have differences in the data qualities that are recorded, or Fitbit versus Apple Watch, or things like this. And so there's an opportunity here to A, quantify those differences, but then B, in cases when there are differences, to mitigate them through algorithmic fairness and bias techniques, but applied to these kind of understudied areas like device type, which is not traditionally what algorithmic fairness has been applied to. And so I'll talk a little bit about all three of these, starting with the subjective and nuanced health conditions. So because of the time, I'm going to spend very short on each of these, but I highly recommend, if you're interested, reach out to me, ask questions at the end of this, check out the papers, and I'm happy to collaborate with everyone on this call. So in terms of human in the loop AI for psychiatry, I thought it would be useful to start with just a quick overview of the diagnostic process in psychiatry. So when a clinician is evaluating someone for some psychiatric diagnosis, what they tend to do, and this is across many things in developmental delays and psychiatry and anything behavioral related, is that the clinician will oftentimes perform interviews or things like this, and then rate the subject on a 0, 1, 2, 3 scale, so a categorical ordinal scale, where 0, for example, in terms of behavior, might correspond to never exhibiting that behavior, and 3 might correspond to always exhibiting that behavior. And so I want to give the example of autism, which is something that I work in, and a condition that I care deeply about, is emotion expression. So a clinician might be evaluating a child for their emotion expression during conversation, and might rate that child on a scale from 0 to 3, where 0 might correspond to never emoting during conversation, 3 would correspond to always emoting, 1 would be sometimes, 2 would be often. And so let's say the clinician is evaluating that child and records a 2, so often. So the clinician will put that 2 down on the score sheet. The clinician then proceeds to do this for several other behaviors. And then to arrive at a diagnosis, what the clinician does is sums up the 0, 1, 2, 3 categorical ordinal variables. And if that sum exceeds a threshold, then a diagnosis is provided. If that threshold is not exceeded, then no diagnosis is provided. And so you could already start to think about some of the challenges here in terms of machine learning. And it's a very interesting status quo here. And so what we did in our experiments a while ago was to train a machine learning model to predict the diagnosis from these clinician inputs, which is kind of trivial given that it's exceeding a threshold. But what we can do with that model, if it's learning nonlinear interactions and collinear features and things like this, is to apply feature selection techniques to deprioritize those features that might not be as predictive for the autism, and emphasize or prioritize in a ranked list those features that are the most predictive. And once we identify these core sets of features, what we can then do is try to build automated pipelines to quantify these features. Now, the problem And I've had this slide for a few years, this particular slide for a few years now, and I feel like it gets less relevant every year with all these LLMs, but still today it's relevant. And the problem is that machine learning models cannot yet predict or understand complex behaviors. We've been experimenting with this over the past month. They still can't do it for the video analysis popular open source LLMs, where you could, for example, provide a video of a child and ask the model to quantify whether the child would enjoy participating in social games and interactions. And right now, it really fails. And the reason I believe that they still fail today is that these video analysis models, or if you put in a video into ChatGPT and ask it to analyze it, it's really good at understanding what literally happens in the video. But for answering this type of question, you're not just analyzing and talking about what's literally occurring in the video. You have to make some sort of inference and judgment and apply some sort of human reasoning. And right now, the LMs don't do this. Now, I don't know, in 5 years, probably they will. So who knows, or maybe 10 years, but as of today, and maybe they won't, it's hard to know. But in the meantime, we need a way to be able to work, have humans in the loop to essentially do this, because humans are really good at answering these questions. Now, not all humans, but many humans, depending on who they are, could be really good at answering these types of questions. And so what we can do is this human in the loop AI paradigm, where we have a human answer multiple choice questions about the video. So that's converting this video into a 0, 1, 2, 3 feature space for each multiple choice question. So as the human answers various questions about the video, what kind of happens on a technical level is you get this high dimensional, 5D tensor linked with RGB time, maybe it's just 4D tensor. I think it's 5D. Anyways, who cares? This is the large dimensional tensor, and you convert it down into a very compact feature representation space of, in this case, a one-dimensional vector where each element just has 4 possibilities. So that's much easier for machine learning models to work with than that original feature space, and much less prone to overfitting and all that kind of stuff. And so we can then feed that behavioral feature vector into a machine learning model that will make the final prediction. And so this is perhaps the simplest instantiation of human in the loop AI, and there's not really a loop here, but you can see how you could take this type of idea and expand it to do more sophisticated things like iterative Q&A for assigning different humans to different behavioral tasks and things like that. And it all kind of builds off of this general idea. And so what we were able to do is evaluate this, and it performed well. And we ran some crowdsourcing experiments, and we were able to figure out who from the crowd is really good at answering these questions, who isn't. It's kind of interesting that, parents of children with autism were actually not too good at answering these, counter to our hypothesis. And we were guessing it's because they were overfitting their intuition to their child. So humans can overfit as well, not just machine learning models. Anyways, we have a bunch of papers on that. We also, very important in human in the loop AI, it's very important to consider patient privacy, because if you have humans in the loop, now that those humans, depending on who they are going to be looking at PHI when they're reducing the feature space. And so one thing we're interested in is algorithmic or technical solutions to preserving privacy while still enabling the humans in the loop to extract the behavioral features that we want them to extract. And so we looked at different strategies for applying these privacy preserving methods, and we have papers on which ones perform well and don't. But for time, I'll leave it there. I'm not going to go into too detailed results in this talk. I want to give you a brief overview of the types of problems we work on. So that's everything for the first issue in the field of consumer digital health. The second issue in the field that I want to talk about has to do more with the inputs to the model, the noisy and heterogeneous nature, even though human in the loop AI could kind of help with that as well. And so the opportunity here that I want to talk about is personalized self-supervised learning. But first, let me give you a little bit of context about the types of data that we're working with. So we're really interested in collecting longitudinal multimodal time series data from wearable devices. So think heart rate over time, SpO2 over time, accelerometer over time, et cetera, et cetera. Those are the inputs to the model. And then we also get time-stamped annotations of some adverse health event of interest. That could be a blood pressure spike. We have a project on that. It could be substance use or craving. We have a project on that. It could be, we don't have a project on this, but it could be diabetes, blood sugar fluctuation. It could be all sorts of things that follow this general paradigm. And what we do is have the end user provide these annotations of the adverse health event of interest, with the end goal of then not requiring the end user to provide these annotations and then automatically detect them with AI in order to eventually trigger a digital intervention that can be applied in a just-in-time manner. So to make this work, we have this idea of an AI model for each person. I guess it's not too novel of an idea. It's kind of simple as well. But it's much harder to pull this off than it may seem, primarily due to the small number of labels that you get when you build a model per person compared to when you're trying to build a diagnostic model that's getting a bunch of data from a lot of people. So that presents a major computational challenge. And so two projects that my lab is working on right now is detecting substance use and craving. We started with like stimulants, but now we're moving more towards cigarette smoking for various reasons. But, you know, follows this paradigm. Or another project we have is detecting stress and stress-induced blood pressure spikes. And playing around with is the blood pressure the input or the output to the model. Same with stress, self-reported stress labels, and there's different translational applications of both of those framings. And so we have some pilot data already collected on both of these, and we're working on preparing those publications as we speak. But the key to making this work is doing this personalized self-supervised learning. So normally when I talk about this in groups, I go into this whole thing about how ChatGPT works. And, you know, it's this, what is self-supervised learning? We, you know, predict the next word given the previous sequences of words. And I think for this group, I don't need to go into all of that. Everyone probably knows how this works. You know, basically you train a foundation model to predict, you know, the next word given the previous sequences of words. And if you have a model that can do that well, then you have a foundational model that can then be fine-tuned to do a lot of other things. For example, to respond to prompts well through RLHF fine-tuning, but it could, in theory, be a foundation for other NLP tasks as well. But I assume everyone here knows that already. So what we're trying to do is take the same idea of predict the next word given previous sequences of words for a foundation model for NLP and apply it to wearable biosignals. So instead of what's the next word given the previous sequences of words, it's predict the missing portion of the biosignal given either the surrounding portions of the biosignal or like the preceding portions of the biosignal. And if we can do that on an individual, then we can learn the nuances of their physiology. Now, this is a simple architecture, but we could, of course, do this in a multimodal manner as well, where, for example, we could build architectures like this, where given two modalities of biosignals synced by time, predict the missing portion of a third biosignal, and technically this first portion of the biosignal would also be an input, but got to work on that figure. But you know, these types of ideas. So it starts to suddenly create some complex multimodal deep learning architectures, especially when the sampling frequency is different from each of the modalities. But it's not too complex. I'm sure all the CPH students could figure that out really easily. And so once we have these sorts of models, we can fine tune it into to predict the tasks of interest that we want to predict. And so we first tried out this idea actually on publicly available data sets. I don't want to go into this in too much detail, but for this public data set that was posted somewhere, I think on like the Nature Scientific Data, which publishes a bunch of data sets. We found one, and it performed really well, the personalized model versus the generalized models. And when we saw the gains in particular when there's a small amount of labeled data, when you have a lot of labeled data, you don't really see the benefit anymore because you have a lot of labeled data, which makes sense. But we don't want the users to provide a lot of labels because that's not a good user experience and people are going to drop off. So this is good that we could essentially get pretty good performance with a small number of labels. And we can look at the subject by subject and see dramatic differences in performance at a fixed number of labels. But it doesn't always work. So I could tell you about when it works well, and that's great. But there's also cases where it doesn't work. So here's an example of a data set where it doesn't work too well. This was a nurse stress prediction task where the nurses were wearing their wearables during their shifts in the hospital during COVID-19. So very highly stressful time for nurses for sure. And were asked to provide these annotations reliably during their shifts. And so as you can expect, there were several challenges in those data that made it very difficult for our method to perform well. So first of all, there was inconsistent labeling across nurses, so between subjects. And the idea is that personalization should be able to help with that in theory. But in addition to that, there was inconsistent labeling practices within the same nurse on different days or even in different hours within the same day. And on top of that, there was a bunch of noise, and sometimes the device was worn incorrectly and all sorts of things. And so while personalization is great under these lab controlled settings and or otherwise highly controlled settings, there's a lot of other challenges that occur when you're in these remote settings and trying to get patients who might not always have time to provide labels well. And so that brought us to the next set of challenges, which is that we need to create human-computer interaction innovations that can enable the efficient and correct collection of data in these remote settings. And a lot of these human-computer interaction innovations are highly computational in nature. So here's just a very simple example to give you an idea of these types of things that we're working on here. So when we're training the model and we get more data, we continuously update the model. So we're always refining it as we get more labels from the participant. Now, we can have the model trained so far make a prediction. And if that prediction is confident, it's predicting 98% for a binary task, or it's predicting 2%, which is also very confident just in the other direction, then there's no need to ask for an EMA, with a fancy way of saying just like get an annotation from the user. No need to ask for that from them because the model's already pretty confident in its prediction. And so don't burden the user in those cases. Now, later, we might output something near the decision boundary, 56%. So it's technically predicting, let's say, stress, but it could have easily gone the other way. And so in those cases, it would be very valuable to get a label from the participant. And so we can, trigger the app notification on the smartphone at that time and to get an annotation. So that's the basics of what we're starting to work on in our NSF project. But we're also looking at unsupervised ways as well. So this is a confidence-based active learning approach, but there's also like similarity-based approaches based on how similar are the different biosignals from other biosignals that occur later on in terms of and it's multimodal, so it's kind of non-trivial into how you do that similarity analysis. But these are the types of things we're working on. And again, we're also doing like HCI design of like what are interfaces that'll help promote data collection. This is just a mock-up that I did, but like something that where we can gamify it. for today's talk, I'm focusing on the computational stuff. And so that is a preview of our wearables work, mainly addressing the noisy and heterogeneous data inputs. Finally, I want to talk about a new line of research that I'm working on, which is the different data qualities across devices. And in particular, in the context of a digital Parkinson's diagnostic that we built. And so we created a website that it says gamified here. We need to change that to like structured assessments, but like structured assessments for older participants, ages 50 and above, I believe, to basically go on this website and complete these mouse tracing tasks and keyboard pressing tasks with the goal of trying to detect tremor-related symptoms in Parkinson's disease. And so we built this website, deployed it, went to a bunch of community events, and got a lot of participants with Parkinson's to complete this, as well as matched controls. And long story, and we did a bunch of feature engineering, and we were able to get relatively good performance. We also did some interesting neural network ideas where, for example, we took images of the mouse trace patterns and fed that as input to train a deep learning model. Interestingly, that performed more poorly, perhaps due to overfitting issues. And so that stuff is all kind of interesting and good, but there's also some issues with our data collection procedures that we're trying to fix for future iterations. But we were able to collect some information about the handedness of our participants and the device type of the participants, as well as their demographics. And we were able to study whether the model performs differently across these groups. And to do that, we applied some algorithmic fairness metrics. Just a brief primer on these, although I think probably CPH people know this, but we have disparate impact, equal opportunity, and equalized odds. These are all metrics that quantify basically what's the difference in performance across groups. And in these cases, we formulated them as ratios. So a value of 1 means fair, and anything further from 1 means not fair. And the further away it is from 1, the less fair it is. And what we found is that basically there were, so for race, we found differences, but we had such wide error bars that we couldn't really conclude anything. But for device type and dominant hand, we actually had more compact error bars and values for a lot of these metrics that were really far away from 1, indicating that the model for device type performs more poorly for Windows devices versus Mac devices. And I would guess the reason there being that even though, interesting, we had more data from Windows users, there's a lot more heterogeneity within Windows devices. You have a Dell, or you can have, Lenovo, or whatever it is, and they all have their own idiosyncrasies versus with a Mac. If you have a Mac, it's a Mac. There's only so many Macs you can have, and it's highly constrained. And so, interestingly, it's not always about the amount of data. Actually, we should put this in the paper. I don't think we talked about that in the narrative enough, but it's not just about the amount, but it's also about the heterogeneity and variability within the data. So if you have more data from one group, but it's much more varied than a group where it's much more structured, that's also an issue. So anyways, for device type, and also for dominant hand, as is well known, there's much more people who are right-handed than left-handed. And we, as a result, saw that the model performed much better for right-handed individuals versus left-handed, which sort of makes sense because a lot of the tasks involved tracing with the mouse, and there's probably different idiosyncrasies in terms of right-handed versus left-handed tracing. So now we're looking at solutions to these. We're looking at things like we're trying to submit a paper on multi-objective adversarial debiasing to solve these. We did a fair feature selection approach. I would like to do like a standard like fairness, regularization, optimization type of approach as well. But there's definitely room. We have this data set, and it's kind of if any students are interested, there's a lot of room for solving these disparities algorithmically. So definitely reach out if you're interested in that. Happy to share the de-identified data set. And so anyways, that's just a overview. Actually, I think I'm good with time. I took out all the results slides, but maybe I could have kept them in. But happy to answer any questions about that. But in summary, I talked to you today about this field of consumer digital health informatics, which is emerging, perhaps not as mature as radiology or EHR-based machine learning and computation, but something that I think in the future can be very complementary to those two fields as well, and talked about some of the challenges that are somewhat unique or at least overly enriched in this field in terms of computation. So with that, I would like to thank my funding sources and mentees and who do all the work and collaborators and this slide's a little out of date, so many more people to thank as well. Thank you so much for your attention, and I will pause now and take any questions.
Thank you. Excellent. And I should say that on the, among our attendees are students, other faculty members, etc. So there may be a range of, questions and or interest in different aspects of the work. I would invite anyone to raise their hand, and happy to call on you. In the meanwhile, let me just ask you just one clarifying question, because I wasn't sure I was tracking. On the substance use and cravings metric, what was the wearable device actually measuring? I saw that there was fluctuation in the input, but I wasn't sure what the input was. And then a collateral question is, really appreciate your reference to the sort of human-centered design, etc. I know that was a little bit outside the scope, but I'm curious, when you were doing the design of the mouse tracing, etc., and consulting with people, what kinds of things did you discover that changed the way that you designed the intervention? Yeah. And then Adrian, I see you, and I anticipate that you must have a question because you have appeared on the screen.
Yes, these are both really good questions. And so I guess I could start with the substance use. So for those, we were using a Fitbit device. And so there's, I think, a slight disconnect between the figure I put and like what's actually recorded. So what was recorded by the Fitbits is step count per minute. And so what are the number of steps per minute, as well as average heart rate per minute, as well as various sleep metrics. So these are like things like SpO2 and other like heart rate variability that are only recorded during sleep. And the intuition behind just being able to predict with step count and heart rate is because we were studying a lot of stimulants. If you just think about it a little, like if your heart rate shoots way up and you're not moving, like you're drinking a lot of coffee or a stimulant, so it's probably that was the signal that was being detected. And so, but when we analyzed the data, we found that like we didn't get amazing predictive performances, but we were able to kind of look at the AUROC curve and try, and for each individual get to either really high sensitivity with specificity above 50% or go the other way around, high specificity with sensitivity still above 50%. And if you think about the eventual digital interventions that we're talking with collaborators to create, there's use cases for both of those. So if you have the high sensitivity option, then basically that means that you're never missing when they're using or craving. And by the way, these are two separate models, and of course use performs better than craving, but for you're never missing that. And there might be some examples where you don't want to miss anything. If it's, for example, an opioid or something where you really want to catch it. On the other hand, there might be other types of digital interventions where, let's say, you're calling the clinician every time it's detected, and maybe it's not the type of substance where it's really going to harm them just from one use. But you want to be able to occasionally intervene when they do, then the high specificity is where you want to go. So we have some collaborators in the digital interventions for substance use, who are experts in that, and we're starting to partner. And also, and so I think for the Fitbit, this was good, like initial work. We're eventually going to move to more granular wearables, and in particular the Empatica Embrace Plus, which collects heart rate variability, skin temperature, electrodermal activity, accelerometry, and I think a couple other things at a very granular level. Like you get the raw signals rather than Fitbit's processed output. So, but I thought it was interesting that we could get that good of a performance just with Fitbit, just from heart rate and steps, and then preconditioning on the sleep metrics. But I think there's a lot of possibility once we move to more expensive but more granular wearables of improving the performance, and then co-designing the digital interventions there. For your second question, which was about the human-centered design for the Parkinson's, so we did run a co-design session. We also went into the community, and so like, I, for example, woke up on a Saturday morning, went to the Hawaii, I was at University of Hawaii at the time, went to the Hawaii Parkinson's Association event that's annual, and became really actually started collaborating very closely with the president there at the Hawaii Parkinson's Association, who sadly passed away. But he was, he just like through talking with him and partnering with him, we were really able to, he helped, like just him was helping us co-design our initial diagnostic. But then after that, we ran a more structured co-design session with 20 individuals in Hawaii with Parkinson's, enriched for Native Hawaiian and other Pacific Islanders to get that perspective as well. I need to figure out, like, we ran that and we never published on it. So I need to go back and see like what happened to that. But we did run that, I think, because I was transitioning schools. It's probably the last, but that data is still there. So I think we should revisit that. And if anyone wants to help do that qualitative analysis, we do have those transcripts.
Adrian, please.
Yeah, this is great. Thanks so much, Peter, for giving us a glimpse into your world. I was curious about the human in the loop kind of model that you had, and I was thinking about how flexible you think that approach can be to apply to different use cases. One thing that comes to mind, something that we're doing in some interventions, is thinking about how to use, LLMs, AI for adaptation and personalization, in particular cultural adaptation, let's say, right? And it can move you so far, but then there's things that you have to check, right? And I'm curious if, something like that, or how broad you think this model could be applied beyond that kind of use case that you presented with, autism in particular.
Yeah, no, that's a good question, and there's several different angles to it. So one study that we are trying to run right now is in collaboration with the Wall Lab at Stanford, is to try to partner get collect videos from Bangladesh and seeing whether crowd workers or other humans in the loops from the US, whether their annotations are able to transfer well across those across different cultures, and so that's a starting point, and then going vice versa and seeing clinicians. And it gets really interesting because a lot of these social and behavioral features, there's a cultural aspect to it. And so what might be a 2 in that 0, 1, 2, 3 scale for one culture might be different for another. And so we are looking into it. I don't know yet what the answer is, but it's a very important topic and something we are actively studying.
Cool, thanks.
Other questions or thoughts from the assembled? If you want to follow Adrian's example, if you have a question and appear on the screen, you are welcome. And if not, let me just say, first of all, great thanks to you, Peter. Second of all, sending good wishes to family, as I know that you are expecting relatively soon. But I did want to make everyone aware that if you haven't yet registered, registration is open and the link is in the chat for an upcoming conference on April 29th on Frontiers in Computational Health. That includes, it will include speakers from UCSF and Berkeley and outside. Eric Horvitz, who's the Chief Science Officer for Microsoft, will be the keynote. The call for posters is also open. So for faculty members or students, I see some students on this list who have already submitted posters. Thank you. For others, really encouraging submissions by early career researchers or trainees that have to do with how computation can impact health sort of above the skin, less at the discovery level and more in the context of clinical or community health or everyday life. So Peter, your work, very relevant to that. Yeah, I'm hoping to see you all at that conference, if not before. And Peter, many thanks for the presentation. Looking forward to seeing the results and digging in a little bit more deeply.
Yes, we'll do a follow-up talk with the results.
Looking forward.
Thanks so
Okay,
much.
bye all.
Bye.